Welcome everyone to today's webinar. I am Ayla Ellison with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. In about a week following the webinar, we will be sending all registrants a copy of the presentation to the email you used to register. Please be patient as the post-webinar preparation of materials can take some time. It is now my pleasure to start today's webinar by introducing our panelists. Dr. Ruben Amarasingham is founder and CEO of Pieces Technologies Incorporated, a healthcare information technology firm that specializes in clinical decision sciences. Dr. Amarasingham is also the founder and past president of Parkland Center for Clinical Innovation, a scientific research institute based in Dallas, Texas, whose focus is biomedical informatics and gave rise to Pieces Technologies. Dr. Amarasingham invented Pieces VS and Pieces Iris, cloud-based systems that improve the quality of care throughout a patient's journey. Pieces uses natural language processing, predictive modeling, machine learning, and artificial intelligence to achieve these aims. Dr. Amarasingham is a national expert in the application of informatics concepts in healthcare and public health and the use of innovative care models to reduce disparities, improve quality, and lower costs. He has 16 technology patents assigned or pending worldwide, including the Pieces VS system, which is live in multiple U.S. hospitals and health systems. Matthew Lawrence has nearly 20 years of experience in the healthcare industry, with his primary expertise being health system operations and administration. Currently, he is the Vice President of Innovation for OSF Healthcare. Healthcare innovation, whether in clinical or the business zone, is a key initiative for OSF Healthcare. Matthew is involved daily in vetting healthcare solutions and determining what processes and technologies would provide benefit to the system. He works closely with clinicians, technology experts, and various professionals with specialized expertise to test disruptive technologies and understand the best way to accelerate adoption of those chosen for implementation. An 18-year veteran of OSF Healthcare and a graduate of Bradley University's Executive MBA program, Matthew has extensive experience in healthcare and business administration, project planning, performance improvement, and leadership development. Matthew is passionate about solving the most difficult healthcare problems and discovering opportunities to advance the industry. At this time, I am pleased to turn the floor over to Dr. Amarasingham to begin today's presentation.
Thank you for everyone that's joined in the audience. Today we're excited to talk about our work at Pieces and, more importantly, Order of St. Francis's approach to connecting the community. Wanted to just move on to introduce OSF.
Thanks everyone for joining today, and thank you to Becker's for organizing the webinar, and especially to our partners at Pieces for inviting us to be a part of the panel today. At OSF, we really have a long history of innovation, starting with our sisters, our founding sisters, getting on a boat to come to America almost 140 years ago. I think about how brave they must have been to make that decision. There's been several things throughout the history of the organization that I think of that are very innovative. For example, being one of the first pediatric life flights and developing one of the original EMRs. We don't think of innovation at OSF as a strategy or really a department. It's really part of the culture at OSF. Our sisters are still a major part of our board and executive leadership, and that really includes the governance and execution of innovation at OSF.
I just wanted to take a moment, this is Ruben Amarasingham, to talk about at Pieces how we've conceived and developed our software. Specifically, our work around connecting community organizations really started with an initial patient experience that I had at Parkland Health and Hospital System. I admitted a patient to the hospital, was really on their 6th admission, and the individual was homeless and didn't have really strong social support. Came in with pretty severe hypothyroidism, in a form of hypothyroidism called mixed edema coma. For those of you who are clinicians in the audience will be familiar with the severity of that. And the patient was admitted to the intensive care unit, had a prolonged rehabilitation. And at the point of discharge, I was interested with my team to try to understand why was there this repetitive cycle in and out of the hospital. We found that the individual was staying at a shelter, who was doing terrific work, helping this individual get a handle on life. And we were able to work out a care plan with that shelter that ultimately stopped the cycle of hospitalization and readmission. And it dawned on us at that time that there's just these fantastic organizations in the community working on a wide variety of social determinants of health, from housing to nutrition to other things. And how can we then create a program and ultimately software that could help make connections between hospitals and community organizations, and that birthed our work in this space. So I wanted to introduce the two software platforms that work in concert to try to attack this problem. The first is called Pieces Iris, and essentially it's a referral, connection, and case management platform really designed for community organizations. And you can see the types of community organizations that it's been designed for, really to manage all of their client needs, and we'll show you an example of that. The other platform is Pieces Decision Sciences, and this is designed for the health system. Pieces DS uses natural language processing, which we'll demonstrate. It uses an advanced form of artificial intelligence called clinician-in-the-loop artificial intelligence, and has a specific focus on identifying social determinants of health to then, identify risks and create whole person care plans. Pieces DS helps health systems in a variety of ways. You can see some of those listed on the right with readmissions, length of stay reduction, trying to make improvements on hospital-associated infections, and big problems like early warning system and sepsis. These two platforms combined help us realize a vision of a connected community. One of the things that I wanted to point out here on this slide is that our vision for how we improve health systems connections with the community really focus on the community organizations themselves. And what you can see here is we've designed IRIS in such a way that organizations can use it for their own needs, but also what these lines indicate is that they can communicate with each other. So a food security organization or food pantry can communicate and make referrals with family and social support, with housing and utilities. And the reason why we think that's important is because you want to, separate and apart from the health systems, you want to be able to build what we call the musculature of the community, that these community organizations can work together by themselves, independent of the health systems, to be able to raise their effectiveness. And that's a core element. I'll turn it over to Matthew to talk about his view of this.
Yeah, so now that Ruben has defined the two different platforms that we're using, I just want to take a step back and talk a little bit about innovation at OSF and why Pieces makes such a great partner for us. And so I think many of you in the healthcare industry or even in other industries would agree that this word innovation is a very maybe somewhat overused word, or more likely in all organizations and individuals define it differently. And so early on, we worked with our board here at OSF to define what does innovation mean at OSF. And we purposely took words like transforming, value, patients, and communities directly from our mission statement to reflect the importance of the connection of innovation to our mission. Then the next thing that we did with our board and our executive leaders was we took them about 10 different areas of things that we thought we could focus on in healthcare innovation. And I think those of you that work in innovation, you recognize very early that there's so many things that you can do that without a strategic prioritization exercise like this, it's likely impacting your ability to be successful. So these areas of focus that we prioritize, these 4 areas, is really an example of why we identified the work that we wanted to do with a partner like Pieces. As you can see that this work is directly related to our area of focus around more for those with less.
This is an example of the deployment of the Pieces Iris and Pieces Decision Sciences in one city, in particular Dallas. And all of the dots here represent either implementations of the Iris software at community organizations and implementations of the Pieces DS software at health systems. One of the things that we think is really important, that we hope will be evident as we talk about our work, is that the deeper the connection and the number of nodes or organizations that are using the software, the more powerful levers that a health system has and frankly the community organizations have to achieve their missions, because you can then refer patients and make sure that they have a closed loop connection around a variety of needs that aren't often clinical. And so that's kind of our vision for connected communities everywhere. One of the things that we wanted to kind of highlight is we think it's really important, obviously, to focus on outcomes. That's important for health system leaders, and there's a number of reasons why that's critical. These are some outcomes that we focus on in every community that we work with. Obviously, readmissions is a critical outcome because the ability to create stability outside of the health system is part of the basis for being able to reduce rehospitalization. Second, you can see you want to see activity and usage. So in one community, we're showing 147,000 clients being using the services through Iris, 818,000 documented encounters, a high, healthy level of interagency referrals, which means that organizations are communicating with each other independent of the health system. And over on the right, you'd like to be able to say that these high-risk patients, the high utilizers, high-risk patients, are concentrated among these community organizations, which means you have organizations in your community that are serving, as part of their mission, the highest risk patients of these health systems. So that's an important metric to see, are we triaging and focusing on the right individuals? So that's really important measure as well. And then finally, are we tackling the key comorbidities that have an impact on health? And so diabetes, hypertension, heart failure, COPD, these are all important conditions. So we think it's important in any kind of community initiative like this that you're focused on real measures, measures that are very important to health system leaders that really can bring ongoing traction for the health system to participate over time.
So I just wanted to use this slide to depict the broad geographical area that OSF serves and their patient catchment areas. We really do serve a diverse size of populations, all the way from an urban area in Peoria of a population of 300,000 with a 700-bed quaternary tertiary care center, all the way down to serving several rural communities with critical access hospitals that may be as small as 25 beds. And when I think about the challenges that we face just in connecting our own healthcare system across our ministry throughout the entire state, what we refer to as our connected care program, let alone our challenge of connecting the hundreds of community-based organizations that serve our communities as well.
So I wanted to take a moment to start talking about our Pieces DS platform, why we think it's important to this process. So Pieces DS is a cloud-based software system that sits on top of health systems information systems. You can see some of them listed on the left, both electronic medical records and data warehouses. Pieces takes the data. It can take lots of different types of data. One particular focus is taking not only structured data like vital signs and laboratory data, but more importantly, in some ways, the notes that doctors write, nurses write, case managers, social workers write. It takes all that information, processes it, and then is able to make sense of that data specifically for the topic at hand here. It's looking for all of the social determinants that may impact a patient's case. What you see over on the right is a clinician, one of our clinicians on our staff, that are specifically assisting the artificial intelligence system to improve and learn more and more. We know that things are documented in different ways. There's potential missing data and other things. And so the Pieces AI system actually queries clinicians on staff at Pieces Technology to continue to learn, and that allows it to have a very high level of accuracy. Pieces then runs various models. You can see some of the models that are talked up there at the top of the screen to help improve outcomes, and specifically looks for social determinants that need to be addressed before the patient leaves the hospital. It then makes its recommendations and assessments all directly in the electronic medical record. One of the things that we wanted to talk about is how does a system like Pieces achieve a high level of performance? And we use an approach called clinician-in-the-loop artificial intelligence. Essentially, you can see these are kind of live views of Pieces learning. And essentially, when there's areas of clinical ambiguity that it needs to distinguish, it actually loops in a clinician who helps arbitrate what is the correct answers in certain circumstances and learns from that, and it's able to get a highly configured understanding of the health system's documentation, and this allows for a high degree of accuracy. What I wanted to do here was talk now through how do we go about the process of connecting the health system and all the processes within there and to the community. And so what you see here is just a workflow. We really think the workflows are critical. You know, how do we make sure that these workflows work across the health system to the community? So imagine a patient comes in the health system. The first thing that Pieces will do is review everything in the electronic record to understand what are the social determinants that may be at play. Is there homelessness? Is there vulnerabilities with the patient's family? Is there other social determinants like food insecurity that needs to be addressed? It'll do that by reading everything in the electronic record and in any other systems that the health system wants to expose to Pieces. It then makes its determinations and activates teams within the health system directly through the EMR. And then at discharge, if there are community organizations that need to be brought into the care plan, the health system can make referrals through IRIS to community organizations. Then the patient may go to that community organization for whatever reasons, both the reasons that they were already going to that community organization as well as when the health system initiates it. They'll get their services at the community organization, and the health system will know when those services are completed. And Pieces has been monitoring all this activity, trying to make sure we're making progress on important outcomes like readmission, length of stay, and continue to improve the workflow. So let's walk through how this works. So what you're seeing here on the next slide is an example of how Pieces looks for information. Here's an actual case where a person came in with diabetes, obesity, was noted that they were homeless, presents with 2 days of confusion and fever. Then it was also noted by the physician that the patient was septic and that they were going to treat this patient empirically with broad spectrum antibiotics and fluids. Very valuable statement. You know, this was written as a text narrative, and Pieces in real time will read this information, both the information above, which is structured, as well as that note, and immediately in real time make this assessment. You can see a number of things are noted. One thing that it noted was that there was homelessness. Didn't know, it couldn't comment further as to whether that's currently present or not. It noted a history of homelessness. You can also notice other things, that it noted that there was sepsis, and beyond just noting sepsis, it was making a determination that the physician is aware that sepsis is present. So it's really trying to understand context, wants to understand, do we need to make an alert? Not in this case for sepsis because the physician's already aware. So there's a number of really valuable features of Pieces to be able to do that, including being able to identify social determinants. Here's another example of Pieces actually working in the background. It's reading notes, making determinations. It's reading the actual doctor's notes in real time. And what you can see down at the bottom is an example of the semantic understanding of Pieces that's valuable. And so you can read, you can make out that it says that a consultation feedback is needed according to PIECES because it was noted that there's a final plan for antibiotic therapy pending infectious disease recommendations. So I was able to read that, understand that that consultation is needed prior to discharge. And so it can apply those kinds of complex understandings to all aspects of the chart in real time. So return to the workflow, what I think I showed you just there was PIECES' ability to kind of read everything in the chart and understand all of the complexities of the patient, and specifically then understand also what social determinants are present. Next step then is to both activate and notify the right caregivers. So the way that PIECES does this is here you can see PIECES activates directly within the electronic medical record. These are different electronic medical record views. It can do this through specific alerting systems that the EMRs employs. We can also, PIECES can also send information to smart devices or have off electronic medical record views, whatever the preference of the health system is. And this is all to make sure that the internal resources of the health system are notified about important information around the patient. Here's another example of how a health system is using PIECES. And you can see this was information presented to multidisciplinary discharge planning and case management notes. And you can see that PIECES here is saying this patient requires a couple of different interventions, specifically around insurance, around post-discharge placement, and it's noting social vulnerability. And PIECES is taking from the note and saying this person's homeless and has food insecurity. So these are things that we're going to have to address when they leave the hospital. So on this slide, we've now we've gone through the hospitalization. We've identified the social determinants as well as clinical needs. The clinical needs hopefully were addressed. PIECES helps support that. But now we're approaching the discharge, and we want to make sure we can connect to the community. Here's a map actually of Peoria, Peoria, Illinois, where this is being deployed at OSF. And the first concept I want to introduce you to is there's a number of community organizations in the community. And so you can see here that when the person is leaving one of the OSF hospitals, you want to be able to connect to community organizations to identify and address the right problems. But those community organizations may also want to connect with organizations that are not on IRIS, right? So they may be using a different software system. IRIS allows them to make referrals to non-IRIS organizations. That allows you to expand the influence. One of the things that we've been really excited by is that oftentimes we think that this needs to be deployed in a grassroots spiral mechanism. When the community organizations are working together, they're often communicating, and more organizations sign up for IRIS. The more organizations are in IRIS, the more powerful the ability of the network to meet these community needs. And you can see in this example, community organizations are telling each other about this platform, the partnership with the hospitals, and more organizations are on IRIS. And so, Matthew, I certainly wanted you to talk about OSF's vision for this.
Yeah, I just want to add a little bit more context to the comments that Ruben made, and I'm sure that many of you on the line are experiencing these really similar scenarios. So if you look at the center of the slide, I realize it's in small print, but right in the center is a community named Streeter, and that community is probably 100 miles from Chicago to the north, 60 miles from Peoria to the southwest. And then in these other surrounding, and it's a population, by the way, of about 15,000 people. In these other communities where we do have hospitals, OSF hospitals, Mendota, Ottawa, Pontiac, they are all the population anywhere between, I would say, 7,000 to 18,000. And so this really does represent this, this network of healthcare in this very rural geographic part of the state of Illinois, where you have these hospitals collaborate with the need to collaborate with these community-based organizations. And one of the features of IRIS that I really love, and Ruben touched on this, is that there is this somewhat social media network that begins to happen as CBOs come online. And so just in the short amount of time in our first implementation in the Streeter community, because when they are making referrals CBO to CBO, agencies that are on the platform, when they refer to an agency that's not, they are asked to join. And literally just in the first couple of weeks of doing this, we've already had that occur in one instance. So a little bit about the collaboration that we are doing in the community Streeter that I mentioned. When you look at the left side of this slide, so when the hospital and the community closed, which was not an OSF facility, we took an approach to how we're going to focus on improving health and wellness for that community. So that included renovating a building, offering a collaborative community space, a place that community-based health and wellness steering team, or we created a community-based health and wellness steering team. And then we deployed the IRIS platform to connect all the community-based organizations and our local healthcare team. So we anticipate that in the state of Illinois, for example, in the catchment area that we serve, we think that there's potentially another 8 hospitals that could be closing in the communities that we serve. And so we're standing this up as a model for what will be future best practice for how we serve those communities. And it's really a three-pronged approach between the facility and how you repurpose that facility, a healthier community, and then using digital tools like IRIS to stay connected with those communities. So the model that we have a community-based committee that's established a specific health and wellness goals for the community, and then we're implementing policy and programs to bring about community improvement. And this is a model that's based on various best practice in other communities that have seen significant health improvement outcomes across the country. And then we're using the IRIS platform to connect our clinicians and our care teams to the CBOs and to connect the CBOs with each other. This last area really helps us to further address those social determinants issues that Ruben touched on before. One other significant point I want to make about this slide is I'm oftentimes asked the question of how are we deploying a technology like this in the communities that we serve. And I really like to think about this as it really is a change management project in some ways, and partnering with our community-based organizations and helping them see the value of what the return that they're going to get for having a platform like IRIS. And on the left-hand side there, you can see some of the initial organizations in the community that we're partnering with to deploy the technology. And one of the unique organizations or stories that I like to tell when we talk about this work is that even the high school in the community is an organization that we're onboarding with this technology, because we know that in these very underserved rural communities, oftentimes children going to school is probably the only hot meal that they're getting each day. And so by connecting the school with our local food banks, we think it'll provide us an ability to provide healthier nutrition to those young individuals.
Thank you, Matthew. So just returning back to the workflow, and Matt, just try to hold in your mind what Matthew just talked about. So you have these community organizations that are providing extremely valuable services. And you, at the end of a discharge process, you might have a case manager at the health system that needs to make a referral to both, let's say, a nutrition and weight management program in the community, as well as a, general health program around housing. And so what you're seeing here is a case manager very easily able to go into IRIS from the health system and make those 2 referrals. And so you can see here emergency shelter and nutrition weight management to 2 of those community organizations that they need to connect to. So now that takes us through all the way through the health system. And again, that could be the clinic as well. But basically the health system is the patient had come in for a variety, whatever their clinical needs were, but we're also identifying social needs. And at the end of the health system process, you're now making a referral into the community to help address at least the social determinants and the health system's obviously addressing the clinical determinants. So now we're in the right-hand side, fully on the far right of the community. So there, the patient's receiving a referral at the community-based organization. Excuse me, the patient referral has been received at the community-based organization, and they're coming to that community-based organization for services. And so what we're going to show you now is that community organization using IRIS for all of their needs. So what you're seeing here is what we've designed, which is a very simple to use yet elegant tool for community organizations to meet all of their needs. And in this particular case, you're seeing a community worker, a community case worker that is taking in that patient that had come in for that referral. And you can see it's nutrition and weight management. They've done a consent. We think it's really, we spent a lot of time working through consent processes, which are really critical. And now this is the main page of that patient that was referred to, Kathy Jones, in this particular case. And there's a number of activities that this community-based organization can do. There's making sure about enrollments. You can set goals. You can see the various goals. The health systems can participate in helping set those goals, and you can see the various encounters. This particular case, they're now setting up the new encounter because the patient came in. They're showing that it's a weekly check-in, and they're making their notes about what they're doing with respect to Kathy. And when the health system's involved with this process, they're going to be able to know what's actually occurring in the community. This is creating that closed loop to make sure all the social determinants are addressed. So you're really, truly developing a whole person care plan. And so we're just scratching the surface here, but these are the variety of things that the community organizations can do with the IRIS platform. And a lot of this can be personally configured for the variety, for the different types of community organizations that are there.
So I've referenced the community of Streeter several times in our presentation, and just to dive a little bit deeper into the work that we're doing there. And I would take you back to referencing the slide that I talked about earlier about our four areas of focus and innovation being around simulation modeling, aging in place, social determinants of health, and radical access to care. And I think the really unique thing about this project is that there's aspects really of all four of those different focus areas running throughout the work that we're doing there. And so there, a little over 2 years ago, there was a community hospital that closed. And I think, I mentioned this earlier as well, we're going to see a lot more of this where these small community hospitals who have probably gone a decade or two with putting little to no capital investment in infrastructure, when they have an infrastructure problem, there's going to be a very, very short notice from the time that that's identified until the time that they unfortunately or likely will have to close. And that's part of what happened in this community. And I think one of the many important pieces of this work that we're doing is helping prepare us for how we'll address that when that happens in other communities that we serve. And so I love the word journey on this slide, because this really is going to be a multi-year journey, partnering with the community members, government officials, and local business leaders in this community to create a healthier Streeter. One of the very first things that we did in the center there is as soon as the other hospital closed, we worked with the state of Illinois to license and open the first freestanding emergency department in the state of Illinois. We added to the primary care services that we were offering in that location, including adding additional behavioral health resources and rotating specialty care from the other communities that we have hospitals surrounding the Streeter area that you saw on an earlier slide. And one of the additional things that we did too is what I would call a really in-depth type of community needs assessment that generated insights of what the people living in the community felt were their challenges to living a healthier lifestyle. And one of the resources that was identified by multiple community members who participated in this process was the use and the access of their YMCA in their community. So we have made a $1 million donation to the Y there, and are partnering on growing and developing more access to their programs. And then on the right there, that's a vision of where we see our journey and our vision for a healthier Streeter going in the future.
So I wanted to just take a moment to, reflect on kind of our approach. For us, I hope the audience can tell it's really about a significant community commitment that comes both from our, patient experiences as well as working with health systems with different approaches. And we think that to really have an impact, it's about making a strong connection with the community that's felt and raising up the assets in the community to solve these complex problems. The second part is we think that you can't divorce the decision support and decision scientist type work in the health system from the connections to the community. And so PIECES DS really focuses on surfacing the social determinants while the patient's in the clinic or while they're in the health system, and making sure that's integrated with the care plan and have a way to actually deal with those issues. I think one of the biggest challenges for health systems is there's a strong recognition that there are things that are hard to control, that are out of their control with respect to these social determinants, and being able to provide a pathway to resources in the community in an effective way is really critical. The third part that we think is really important is probably reflected in the first two again, but taking a truly holistic approach. I really like Matthew's point about change management. I think this is really a new way that health systems are starting to approach whole person care. And I'm excited that from a policymaking standpoint, we're seeing this really coming out of Washington as well, with the Accountable Health Communities work, which is a recognition that health systems, if they can partner with community organizations, they can get better outcomes. So I think we're truly on the verge of being able to get to a true holistic approach to managing patient care, and that's exciting. And the fourth part, I think, is passion. I think every community is different. Every health system is different. I think that we need to make sure that technology is there to serve and support and not drive. It's really still about the passion at the health systems and the amazing passion, I think, in community-based organizations around the country. Probably, by some estimates, could be up to 1 million organizations that are probably not being fully utilized or partnered with, more specifically, with the health system across the United States. So I think if we can tap that passion in the community, I think we can really have a powerful impact on some of these outcomes. So with that, thank you so much for listening, and I think we're going to turn it back over to Becker's for questions.
Yes, thank you so much, Matthew and Dr. Amarasingham, for that fantastic presentation. We will now begin today's question and answer session. So please submit any questions you have by typing them into your control panel in the space labeled enter a question for staff and clicking send. And we will try to get through as many questions as we have time for. We've already had several questions come in throughout the presentation, so I'll go ahead and start in with those questions. And the first one is there any confidential patient information stored in this system?
So this is Ruben, I can take that. So obviously the information that's in the in IRIS from the community-based organizations is only information that community-based organizations wishes to record. We do not, and we have a very, very rigorous process for the transmission of information that requires a triple consent from the health system, from the community organization, and most importantly, from the patient. The biggest thing is that detailed clinical information is not really the purpose of what the clinical organization, the community organizations need. They really need the information about what services that they can provide that would be helpful to the health systems. And so we don't have the same challenge as you might have with traditional health information exchanges that's dealing with detailed clinical information. That having been said, we have wanted to make sure that this technology is built with, obviously all the full HIPAA protections, and it's often resulted in community organizations, really performing their services at sort of a HIPAA level. So we're excited about that and the ability to protect that information.
Great, thank you so much for clarifying that. And moving on to the next question, it is, what were the strategic criteria and system imperatives for OSF when electing to partner with Pieces? On the other hand, what were competitive advantages for Pieces to partner with OSF?
It's a great bilateral question. I'll let Matthew, take the first step, and then I'll respond.
Sure. When Ruben was talking on the previous slide, one of the things I was thinking about what's so important about our partnership is that we've done a lot to describe to you today what the IRIS platform can do and how it can better connect our patients to the community-based organizations. And I think there are other platforms out there that can do that very thing, but that really is only managing the patients that are and when they are interacting with us. So I oftentimes tell this story when you think about a patient's healthcare journey. The health system is really just one really short part of that you're coming in and out of along with that on that patient's journey. And so what's unique about our partnership with Pieces is that the DS platform will allow us to actually surface individuals that need an intervention and sense that for us versus waiting for them to connect or interact with us.
Thank you, Matthew, for that. I mean, obviously, we're excited to partner with OSF for a lot of reasons. One, it's a very value-based organization. I think it takes a certain type of vision to try to move out into the community like this in an effective way, and that's evident with OSF. The second part is that a lot of this work was developed and initiated in a pretty dense urban environment of Dallas, which is a different set of needs and requirements. And it was very exciting. One of our goals all along was to make sure IRIS is built in a way that it could really help in any kind of environmental situation or geographic region. And so OSF has chosen actually to deploy IRIS actually first into the rural community, and then over time moving into the rest of the system, which is pretty widespread across Illinois. So we were really excited to see, can something that was really developed initially in an urban environment really work well in a rural area? It's been really exciting to see that. So I think for a number of reasons, OSF, we're just thrilled to be able to work with OSF.
Thank you both very much. And the next question, it looks like it's for Dr. Amarasingham, and it is, how is the cost distributed for Pieces among the collaborators, such as clinics, hospitals, and others?
That's a great question. So that's something that is really can be specific to the community where it's being implemented. We've been able to come up with ways where this could be both a consolidated or concentrated cost versus being highly distributed. So one way, for example, is that the health system can be the real lead actor in this process, and they can decide, we're going to initiate this in our community, and we are going to support IRIS for X number of organizations, and we're going to sponsor that. And a lot of health systems choose to do that. And IRIS, we think we have strived to make it very, very affordable. And so for health systems, it's in many cases not a very difficult decision to say, hey, I'd like to just support all these community organizations and give them IRIS, which is a platform they can use independent of whether or not they're connecting to the health system. And so there's this great community benefit. The second part is that the community organizations themselves can purchase it, just that they need a platform that they're going to manage all their client needs. We try to make it that price, of course, even more affordable, that a community organization can come on. And so it could just be viral. For example, there could be a number of organizations already using IRIS, and then more organizations want to get onto the platform and the network, and they just pay their own organization's costs, and it's relatively affordable. And the last part is there's third-party actors that want to support this in the community. That can be philanthropic organizations or foundations tend to be very interested in this kind of work. So they might say, hey, I want to really support my community by making IRIS available for 1,000 organizations. And then it's not too far after that the hospital system probably will want to get on this network or participate. And of course, there could be other actors like health plans or other organizations that are obviously interested in the community set of outcomes, and they could sponsor it. So I think that in all the conversations that we're having, there's a variety of different ways that this could get funded and distributed, and we think there's a number of ways that this is probably going to manifest across communities. Matthew, I don't know if you have any comments that you'd make.
I would just make one quick comment that when we talk about, things like social determinants of health, these really are not just the health system's problem or challenge to solve. These are really our entire community's problem to come together and solve. And so I love Ruben's comment about, there are a lot of ways to get very creative around paying for something like this, because I think we would all agree that there's a lot of passion out there for solving what is probably one of the biggest crises facing our country today.
Thank you both. It's very interesting to hear about all of the different players in this process. And we're still having a lot of questions coming in, so I'm going to go ahead and move on to the next one. And the question is, can pieces interpret unstructured data in the chart?
This is Ruben. Yes, sorry if I didn't make it more clear. That's like one of the main capabilities of pieces, is to be able to read all of the unstructured data chart. And just for those in the audience, unstructured data usually means text data or data that hasn't been put into specific structured fields. So those things sometimes are called, progress notes, history and physical, discharge notes, nursing notes, case management notes. So it definitely reads all of that unstructured data and then can identify the social determinants and helps initiate actions based on that.
Perfect. Thank you so much for clarifying that. And moving on to our next question, it is, how does IRIS address gaps in mining EHRs and any supplemental systems for social determinant details, given much of that is self-reported and patients are often remiss to share those details?
So that's a fantastic question. So there's a couple different parts to that I'll break apart. So first, we think that the first immediate task is to review everything in the electronic medical record and the EMR systems and look for that information. Our experience has been that there's a lot more collected than is recognized, but it's located in formats and ways that don't make them easily extractable. And so pieces, specifically because of the natural language processing, is able to look and identify those things. And it may not be simply that someone has noted in one specific area that this social determinant is there, but it may be looking at multiple places in the chart and making a conclusion that we have a housing assistance problem. So that's point number one. Point number two is that on the IRIS side, which is in the community organization side, there's a lot of different ways to ascertain this data. One, because these community organizations have specific social determinant processes, whatever it's housing, homelessness, food insecurity, education, the full gamut, thousands of different types of social service or community organizations. There is a lot of rich data that's collected. And in partnership with the health system, this allows for a much richer portrait of what's happening with a client, assuming, of course, all of the consents are present. Then when you have that, you can really obtain a lot of that. And so I think between those two processes, you're able to get quite a bit of information on the social determinants.
Thank you so much for that response. And the next question, I believe you may have touched on this a bit in a previous question, but it is, how do you manage HIPAA issues across a wide spectrum of care providers?
So yeah, it's a great question. So number one, the first is that there's a kind of a role recognition of what's needed, and then making sure that that role is complying with whatever the HIPAA standard is. And that's kind of how we determine that. And the second part is that you have a force function, meaning that the software requires data to be collected or to be used in a way that's compliant with that. the most critical component is anything at the health system. So obviously, the data there that's with health systems has got to be meeting all of the requirements of HIPAA, and certainly that's something that we have spent quite a bit of time on. In the community organizations, the goal really isn't to traffic or use clinical data, but to be working within the domain silo of what their specific service category is. And for each of those service categories, there are specific requirements as to what needs to be done, and IRIS reinforces those. And then finally, like anything, like any change management process, you want to make sure that the training is such that all of those things are reinforced. So that's our approach at Pieces. And to date, it's been very successful.
Great, thank you so much for that response. And the next question has several parts to it. So I'll go ahead and move on to that. And it is, how are the patients receiving the referrals, and how does the technology look like for them? And then the other part of the question is, how are CBOs or hospitals following up with the patients, especially with the homeless population?
Yeah, so that's a great question. So the IRIS platform is primarily designed for the health systems and community organizations. So when basically a referral will go to a community organization, and they will be able to kind of see all of the requests that came from the health system. And so that's the way that the referral process works. They would then check in the patient, they would provide their normal services, and they would see the various needs of the patient. So that's all communicated very clearly. At the health system level, the health system can monitor, because they have an instance of IRIS. They can monitor whether the referrals to the community were closed, meaning first, did the individual go to that community organization? Did they have their services met? Were there any other needs? All of that is tracked back within IRIS at the health system, so they can see a full loop of communication.
That last aspect is something that we're learning from our complex care managers, that's the real delighter for this, the IRIS platform, is that they can actually go in and see that a referral they made was completed by the patient. And then more importantly, if they haven't made it, they can reach out to that patient or with some type of intervention to try and re-engage them and follow up with them. And then I think there was a second part of that question about the challenges or complexities of following up with the homeless. And Ruben, one of the things that he touched on earlier is that this really is a collaboration of just technology is just one piece of it, and so there's other things that we're trying in the communities that we're first deploying these technologies in, that involves partnering with our local fire departments, local emergency medical transport teams that really know that homeless population and where they are and can follow up with them.
That's a really good point. And one of the things is that IRIS supports homeless organizations in terms of their needs. So, at the end of the day, homelessness requires a multi sort of community response, and that would be partnering with the organizations responsible for homeless management, and IRIS can help support that.
Great, thank you both. That's really helpful to understand more about how IRIS can help support homeless populations. And it looks like we have time for a few more questions. And the next question is, this platform seems to be appropriate for a smaller community where you can get local buy-in. How tough is it to implement Pieces in a city with 3 to 5 major health systems that may or may not want to share data?
Yeah, that's a fantastic question. This is Ruben talking. Now, one is that we have been able to demonstrate that in a large urban area like Dallas. And what we found is that the best approach is to, understand the long game in this, like anything that's a significant change management process. So our approach, our recommendation, and I think there's a variety of ways to roll it out. We could speak at length as to how to strategically implement this. But generally speaking, if a health system is taking the lead, let's say, in this process, then that health system usually, among the case managers, care managers, they'll know these are the the 10 to 15 organizations that we typically partner with. And so we usually recommend starting there with the highest frequency communicators or users of community organizations that health systems work with, deploying the IRIS network on that. And then what typically happens is other community organizations learn about the effort and want to participate. And you have a growing second circle and third circle layers. If another health system in the market wants to then participate in that network, they simply have to sign up and deploy IRIS, and then they can connect to the IRIS network. So what we found is that the competitive pressures between health systems that you might see in other types of information sharing like HIEs don't seem to be as prevalent here, because you're really dealing with working with community organizations, getting access to them. You're not really sharing the health system data. And so it's worked pretty well. And I think our general view is you start small, you start effectively, you allow the community to see the value of this and get their own buy-in. There's a lot of self-referrals. IRIS gets larger and larger, more and more deployed. And after a certain time, it creates a pull function where more and more organizations, whether it's health systems or community organizations, want to participate. I think that's the most effective way to roll it out.
And I would just add that in the communities that we do have other competitors in the market, we are engaging them first to discuss this opportunity to deploy a technology like this. And by no means am I downplaying the challenges of competition when it comes to healthcare systems. But if there's one thing that we can probably all agree that we can collaborate on, it's this population.
Great, thank you both so much. And it looks like we have time for one more question today. And the question is, what has been the clinician response? One would suspect clinicians are supportive of the goal of addressing unmet social needs, but has that proven true? And are you actively measuring clinician satisfaction?
This is Ruben. I can take this. So number one, it's incredibly important to have clinician support, and so that's something that we follow carefully, very carefully, to the point of the question. I think that it's endemic among clinicians that they are looking for ways to get resources in the community to support their patients. What actually happens is that you can, once you surface social determinants, actually the clinicians usually know. I mean, they're the first to know that there are these challenges, and actually can be concerned that no matter how good the application of clinical care, if you don't address these issues, they know there will be a rehospitalization. They know that there could be some adverse event. So our experience is that they're extremely supportive, particularly if these processes are within their workflow and don't take a lot of time, which is what we've tried to do. What I think is what is the harder process for clinicians is knowing that these resources exist in the community and how to connect to them. And I think the key in any of these kinds of initiatives, whether it's IRIS or some other approach, is how do you make this as little labor intensive as possible? How do you integrate it kind of with the workflow, and how do you make sure that whatever they've already documented or indicated that they already know, that you don't further query them on. So the ability to kind of read what they're already writing in their notes, to be able to tell what's going on, and not query them again about that is really critical, and that's why natural language processing is so valuable for that. So for all those reasons we stated, we find that physician responsiveness to this is very good. It's very high.
Great, thank you so much for your insight on that. And unfortunately, that was the last question that we had time for today. But I want to once again thank Matthew and Dr. Amarasingham for their excellent presentation, and to our audience for participating today. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.